طيب, thank you very much, Professor Ashraf Rida, Professor Said Farag, all the IAVA board here. Thank you very much. The wrap-up of the year يعني is really important, and the highlights اللي اتقدمت والsessions أكتر من رائعة. We are so thankful. Venue كمان جميل قوي. Everything is very well organized. And without further ado, Professor Hany Ragy, Professor of Cardiology في الناشونال هارت انستيتيوت. لما دخلت وانا لسه نايب صغير، دكتور هاني كان is the forerunner اللي قصادنا اللي بنشوفه دايما taking care of the patients, the grabbing them from the CCU to going to the cath lab, taking very good care of them. One of the very important authorities عندنا في معهد القلب، واعتقد في جمعية القلب المصرية وكله. We are so thankful ان حضرتك موجود. And we're really excited to hear what's new with the coronary artery disease. And I'm co-chairing this مع Professor Noreen عكاشة, Professor of Cardiology عين شمس University, وProfessor Walid Al-Awadi, Zagazig University. And we're so thankful for this session, and we're all ears, sir.
Thank you very much, Professor Khalid, for those very kind words. All respects to the professors, chairman and chairpersons, or chairman, chairwomen. Thank you very much for being here today and for attending. And thanks, Professor Said Farag, for organizing this and for inviting me. I'm going to talk about coronary artery disease, which is a broad title, which would include a lot of things, including atherosclerosis and PCI. So I knew that there would be differences. So this is, take a picture of this slide, because at the end of the day, if you had not heard about every single trial on each of the blue squares, then you have to go to Professor Said Farag and تاخدوا باقي فلوسكم. Okay? Already those will be discussed under different aspects today, from high bleeding risk to devices to antiplatelet therapy post-PCI to data on complex patients, physiology and imaging, etc. Because we're in the era of the COVID, even though this is not a coronary slide, it is an extremely important slide to the extent that I was worried that it might not be shown today, but I think Ayman Abou-El-Magd is going to show it, probably, I hope. And it is a new publication from European Heart Journal 2021 on the mechanisms and clinical phenotypes of acute COVID-19, its impact on the heart and long-term sequelae. We now have a new disease affecting the heart, which is post-COVID-19. Why do people get atherosclerosis and one of them just goes and it becomes chronic and the other one gets a STEMI? We have a lot of explanations, including smoking, diabetes, etc. But it turns out there is a definite, distinct risk factors which are genetically predetermined. In one of the most important publications of 2021, which was the Hartshela study, which showed the genetic factors. And because of the sake of time, I'm not going to go through it, but I would strongly encourage you to read this fascinating paper on how you might be genetically predetermined to get a STEMI. The optico ACS study, which actually shown us that that patients have T-cell mediated inflammation in acute coronary syndromes. And it is the closest look we've had so far on the inflammatory pathway in acute coronary syndromes in STEMI. And from the optico heart study, we might actually, from the optico ACS study, there might be actually new treatments and new anti-inflammatory modality pathways. And talking about inflammation, there was a meta-analysis of 5 studies of colchicine on MACE in cardiovascular disease, and it does reduce myocardial infarction and stroke and coronary vascularization and death. And yet this medicine is still underutilized, even though it's very safe, it has almost no side effects. And we should use it because we believe that one of the main reasons it's underutilized is that there is no big pharma inviting people to big lunches to promote colchicine. So we would like to remember this medicine, just like we remember aspirin. The FAME3 will be discussed, which is a trial which basically proved that FFR-guided PCI was not non-inferior. So it was non-inferior to bypass. So bypass still remains the treatment of choice in the more complex three-vessel cardiovascular disease. In less risky patients, PCI was quite good. This is fascinating, and we might have it in Egypt soon. It is the FAVOR-3 trial by Dr. Bo Zhu from China, and what they do is you just take an angiogram like this, and instead of putting a wire and doing an FFR, you have software on your angio system which shows you a QFR. So it's calculated FFR by the angio, and it just shows you the lesion. And then if it looks good, you want to stent it. If you're worried about it, maybe you can do an invasive FFR. It actually was superior. The outcomes were superior to simply angiographically guided PCI in the FAVOR-3 trial, which was presented in the TCT. This trial, the data were presented at the TCT, and the QFR-guided PCI in 1,900 patients was actually superior to angiography-guided PCR. And now, forget about all what I just showed you, which is the new trials this year. The most important thing that happened in coronary artery disease in 2021 was the release of two sets of guidelines. Well, they were both released in December of 2021. So what you're going to see now is pretty new. The first one was the chest pain guidelines. The second one was the revascularization guidelines. To stay within my time limits, Professor Chairman, I'm just going to give the 10 commandments, al-wasaya al-ashra, in each of those guidelines. But I strongly recommend, and I'd be happy to send you that by email, that you download the entire set of slides, which is over 180 slides for each of them. So this was a chest pain algorithm. And the amazing Martha Gulati, who's a friend of Amenable Magda and I, actually, look at this. She used the word chest pain, so you can remember the 10 most important things. So I'll summarize them. The first one, chest, C. Chest pains actually means more than pain in the chest. Pain, pressure, tightness, or discomfort anywhere in the areas you know well, as well as shortness of breath and fatigue, should all be considered anginal equivalents. So you should not have a fellow. These guidelines, by the way, are also designed to teach to the public and to nurses and to ambulance people and to just patients. And you should not have a fellow in your ER who's sending a patient home who has severe fatigue because they don't know that this is equivalent to chest pain. In the ER, you have to be able to differentiate between acute coronary syndrome, massive pulmonary embolism, severe aortic syndrome, which is aortic dissection, and esophageal rupture. These are the four catastrophic events with chest pain. Chest pain is not just coronary, and we should be able to diagnose all that. Second one, number two, high sensitivity troponins preferred. A place like Ma'had al-Qalb, which is still not using high sensitivity troponin, does not belong in the 21st century with us, okay? High sensitivity troponin is the standard for establishing a biomarker diagnosis of acute myocardial infarction, allowing for more accurate detection and exclusion of myocardial injury. Number three, early care. Seek early care for acute symptoms. All patients should call an ambulance or reach an emergency room. Most of those patients will not actually have a cardiac cause, but evaluation of all the patients should focus on early identification or exclusion of life-threatening causes. You have to examine everybody, all patients, and there are ways to get rid of the low-risk patients very early in order not to let a single patient with life-threatening conditions die. Share, number four, the S. Share the decision-making. The clinically stable patients who are presenting with acute pain should be included in decision-making. Information about the risk of adverse events like kidney failure from contrast material, or radiation exposure, costs, and alternative options should be provided to facilitate the discussion. You have to stop playing God and do things like CT and angio for low-risk patients. You have to involve them in the decision-making regardless of the level of education. T, testing is not routinely needed in low-risk patients. So you can have a patient with chest pain who comes to the intensive care unit by ambulance, but you determine that patient clinically to be of low risk. You don't need urgent diagnostic testing for suspected coronary artery disease as per the guidelines. People who do urgent testing for all patients are poor clinicians, and you don't want to be a poor clinician. Pathways. Number 6, use clinical decision pathways. There are algorithms for the chest pain in the emergency department and the outpatient settings, and they should be used routinely. It should not be done based on personal feeling or mood or how the patient looks like. We should adopt the algorithms and follow them. Accompanying symptoms. Women are more likely to present with accompanying symptoms. Chest pain is still the dominant feature in both men and women, but women are more likely to have nausea, shortness of breath, other symptoms. For example, recently a woman with a STEMI was sent home from a hospital because she was screaming and crying. And the fellow said, patients with STEMI don't cry. They do cry because, you know, people are different. Identify patients which are most likely to benefit from further testing, which are the patients are intermediate risk or intermediate to high risk, pre-test risk of obstructive coronary artery disease. They will benefit from cardiac imaging and testing. This is incredible. This is one of the most incredible parts of the guideline. We're not allowed to say atypical chest pain anymore. It's gone. Atypical is gone, because atypical can actually lead to death, because it makes people think that this is not real. So if you think that this pain is non-cardiac, call it by its name. Non-cardiac is in and atypical is out. Non-cardiac should be used if you think this is not heart disease. Atypical is a misleading descriptor and its use is discouraged. This is the probability of ischemia according to the description of chest pain, which you're going to find in detail in the manuscript. The high, which we used to call the typical, is in red on the left, and the very low, which we used to call atypical, which is now called non-cardiac, the sharp, fleeting, shifting, pleuritic, or positional, is now on the right. So if you have a patient who has chest pain only when he laughs or when he presses his chest, you don't really need to image those patients or investigate for ischemia. Structured risk assessment should be used. This is the message number 10. For the patients presenting with acute or stable chest pain, the risk for coronary artery disease and adverse events should be estimated using the evidence-based diagnostic protocols. What does that mean? It means on admission, you do the ECG, you take the risk factors, you do the physical exam, you assess the quality of pain, and you do the troponin. And then from that, you're going to different clinical pathways. If the pretest probability is low risk, they just go home. They can come later for further assessment. If it is moderate risk, they can go to CT or SPECT or any of the excellent echo modalities like stress echo or contrast echo. Now we go to the coronary revascularization guidelines, which were issued almost immediately after the chest pain guidelines, and I'll also do just the 10 commandments, because this is 188 manuscript slide. The first one, treatment decisions with regard to coronary vascularizations in patients with coronary artery disease should be based on clinical indications, regardless of sex, race, or ethnicity, because there's no evidence that some patients benefit less than others, and efforts to reduce disparities of care are warranted. What does this mean? It means if you get an 80-year-old woman from Aswan who's not speaking very good Egyptian slang, Arabic slang, speaking some Nubian slang, and she needs a bypass, she should not be denied that bypass based on how she looks or who she is. We only base our indications based on the clinical indication, and this is because it has been found out that in the USA, I'm not talking even about Egypt, that women and African Americans, Black Americans of African origin, get poor decision treatments in revascularization compared to people who look like Donald Trump and Joe Biden, who get excellent advice. Okay, so we need to get rid of the disparities. And this is the recommendation, number one. Number 2, in patients considered for coronary vascularization in whom it's not clear what is the optimal strategy, we have to do a multidisciplinary heart team. And the treatment decision should be patient-centered, and the patient should be involved in it, and their preferences and their goals in life should be incorporated. So the shared decision-making should be included, and I'll show you this in the next slide. What does that mean? It means we can't sit and look at an angiogram in a heart team and take a life and death decision for this patient. It's not right. It's just not right. This is how the shared decision-making algorithm from the ACC-AHA guidelines. We provide the best evidence of treatment for every type of treatment, including risk and benefit of each option. And the treatment care options are taken in a patient-centered care, looking at the individual values and preferences of this patient, and then we reach a shared decision-making at the bottom. I just want you to go to the last square here, which is post, because we have terrible, terrible lack of the post-care in Egypt. Our job does not end with sending this patient out of hospital alive. We don't have cardiac rehabilitation. We don't have any professional smoking cessation. We don't help them psychosocially. We do help them pharmacologically. And there are no structured management of cardiovascular risk factors and no assessment of outcomes to tell us what we're doing. And this is in the guidelines. Now, what should the heart team do? هل الهارت تيم ده يعني بروفيسور احمد فتحي انا بسالك لان انت يو استابلش الهارت تيم من معهد القلب. The heart team مش قاعده عرب، مش قاعدين شويه واحد بيقول لا 70% والتاني بيقول لا 50. والموضوع مش كده. انت بتبص على الليفت مين ديزيز والمالتي فيسل ديزيز والهاي اناتوميك كومبلكسيتي، كل ده ان رايتنج. وبعدين بتكتب دايابيتس عنده او ما عندوش وتكسيسوليك فانكشن والكواجيولوباثيز بتاعت العيان ده والفالفولار هارت ديزيز، الديجري اوف فريليتي لازم تتحسب. لو عنده malignancy end stage renal disease COPD immunosuppression debilitating neurological conditions liver disease cirrhosis موجوده في مصر كتير prior CVA porcelain aorta واورتيك aneurysm. ما ينفعش ان انا ادخل عيان عنده porcelain aorta وناخد له قرار في الهارت تيم انه هيعمل باي باس ونبص نلاقيه راجع من عند الجراح بعد اسبوع، يا جدعان ده انا عملت له CT ده ما فيش مكان احط فيه الجرافت بتاعي. We should know this. وكل الحاجات دي ما دام هي مكتوبه والليسته موجوده وموجوده في الجايد لاينز ده بيوفر وقت وبيمنع غلطات كتير. وفي بروسيدجرال فاكتورز كتير قوي. الهارت تيم من وظيفته انه يريكومند هتدخل راديال ولا فيمورال، هتعمل ايه هو السيرجيكال ريسك بتاع العيان بيست على اليورو سكور، ايه هو البي سي اي ريسك بتاع العيان، وطبعا في other many patient factors including even زي عباره عندهم بعض الفئات زي المورمونز ما بيعوزوش ياخدوا دم وكلام من ده. نمرة 3 البيشنتس وعندهم significant left main disease يروحوا يعملوا bypass. Surgical revascularization is indicated to improve survival relative to that is likely to be achieved with medical therapy. PCI is a reasonable option compared with medical therapy only in selected patients who have low to medium anatomic complexity and left main disease that is equally suitable for surgical and percutaneous revascularization. النقطة دي عليها جدل رهيب، وبناء على النقطة دي جمعيات جراحة القلب العالمية كلها رفضت الجايد لاينز of revascularization. In big statements just last week, almost all the cardiac societies ما عدا البريتش كاردياك سوسايتي رفضوا الجايد لاينز لان هم بيقولوا لا البايباس مش. اذا كنت هتعمل بي سي اي استعمل ايفس في بالنسبه للليفت مين. Updated evidence from contemporary trials support older evidence ان في mortality benefit in revascularization in patients with stable heart disease normal LVF and 3-vessel disease, severe 3-vessel disease. Again, in those patients, surgical revascularization is the one to improve survival. There is no survival benefit which was ever proven by percutaneous revascularization. It only improves the symptoms. Where revascularization decisions are based on the heart team. دي مهمة جدا. الجراحين الهارت تيم بيوصي الجراحين انه لو كان العيان ده هيتحط له 2 grafts ياخد ليما وياخد radial graft، ياخد surgical revascularization conduit radial graft مش saphenous vein for the second most important target vessel with severe stenosis after the LAD. والبنفيتس معدوده، ومن ضمنها برضو انه مش لازم الجراح يستعمل الناحيه اللي اتعمل فيها القسطره. كل ده في الجايد لاينز، بس مش عايز احط ديتيلز. طب بالنسبه لشغلنا، بالنسبه احنا معانا على البوديوم هنا واحده من البايونيرز اللي دخلوا الراديال انترفنشنز والراديال دايجنوستكس في مصر، الدكتوره نيرين عكاشه. الراديال ارتري خلاص بقى ريكومندد في كل العيانين اللي undergoing PCI who have either acute coronary syndromes or stable ischemic heart disease to reduce bleeding and to reduce vascular complications compared with the femoral approach. وغير البليدنج والفاسكولار كومبليكيشنز، البيشنتس بتوع الاي سي اي اكشلي المورتاليتي بتاعتهم اقل لميكانيزم مختلفه. خلاص فكره انك مش عايز تتعلم تعمل راديال از اوت اوف ذا ويندو. I'm sorry، حضرتك لازم تتعلم تعمل راديال حتى لو كنت كبير في السن، ولازم نعلم الجونيورز ان هو ده الواي تو جو. نمره 7، بعد الداتا اللي طلعت جديد ان احنا مش لازم نمشي العيانين على 12 شهر دابت، ضمن الداتا دي ضمن اسبابها انه one arm of the DAPT اللي هو تيكاجريلور او البراسوجريل قوي جدا جدا جدا. فكل الداتا اوف ذا ديول انتي بليتلت اللي كانت معموله على التكليد والبلافكس خلاص out of the window. So now after consideration of recurrent ischemia and bleeding risk, select patients, which are many patients, may safely transition to either a P2Y12 inhibitor monotherapy or stop aspirin after 1 to 3 months of dual antiplatelet therapy. So if you think that your patients are high bleeding risk, you can actually call them back and try and ameliorate your bleeding risk. What about staged PCI? بالنسبة للستمي, while the patient is still in hospital or in the first 45 days after discharge, is significantly stenosed, which means 70% angiographically. Significantly stenosed, non-culprit artery, PCI is recommended to improve outcomes in select patients. Percutaneous intervention على الترابيزه وقت الانفاركشن ممكن يتعمل في ظروف نادره جدا، بس هو مش ممنوع. اخر 2 سلايدز بروفيسور صبحي. In contrast بقى ال PCI of the non-culprit lesion in cardiogenic shock is discouraged and actually may be harmful. And this is a change from previous guidelines. Number 9 and then number 10 and then I finish. Revascularization decisions in patients with diabetes and multi-vessel disease should be taken by the heart team. Patients with diabetes and 3-vessel disease are bypass patients. They should do bypass. PCI may be considered only if these patients are poor candidates for surgery. So taking a decision on the table by scaring the patient and saying انت محتاج جراحه نفتح صدرك بالمنشار او ممكن احط دعامه بس الجراحه احسن، لا 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 اعملي ده. You can't do that. You can't do ad hoc for stable diabetic patients. They need to have bypass because it's the more superior strategy, and you have to take them off the table and they have to be properly informed. Anybody who says on table lying on his back after receiving tranquilizers and antihistamines, this is not real consent. This is the last slide. Treatment decisions for patient undergoing surgical revascularization, especially bypass, should include a mortality assessment by the STS score. We should tell the patient before they go into bypass فرصة ان حضرتك تتوفى في الجراحة دي، ده لازم الكلام ده يكون مكتوب بناء على كالكوليتر جمعية القلب الدولية كذا في المية. وبرضو الستروك ريسك لازم يتقال. العكس بقى الusefulness of the syntax score in calculating treatment decisions is actually less clear because of inter-observer variability in absence of clinical variables. والسyntax هيقل قوي في الاستعمال. That was all and thank you very much.
ثانك يو دكتور هاني على الوندرفول سمري بتاعت الموست ريسنت جايد لاينز والبيبرز اللي طلعت في 21. I have a question. Did you come across واحدة من الريدنجز بتوعتك على الكوفيد مع الهارت ديزيز؟ هل في أي بيبر اتكلمت على البوست فاكسينيشن coronary thrombosis؟
Okay, Ayman Abul Magd is going to mention this, but having said that, there are sporadic reports of STEMIs and after vaccines. They have not been because you know both conditions are very common. Yani STEMI is a very common condition, and also the vaccines have been given to over 1 billion people. So at least as far as I know, there is no statistical incidence of any concern, but there are definitely sporadic cases.
small
I'm
comment.
mentioning this because يعني احنا عشان المجموعة بتاعت primary PCIs we have noticed في الفترة الأخرانية a very high increased incidence of coronary thrombosis with almost normal coronaries. We just find a thrombus inside the coronary, and especially those who are a little bit younger in age, and they have a recent history of vaccination. Is this just a coincidence, or there is something? I think we have to study such a thing. Yeah.
Yes, it has to be studied. I had a patient of those. He was 38, but you know he was smoking 40 cigarettes a day for the last 10 years. So I mean, you know, I can't say that I can link them, you know. But to be honest, he took his 2 doses.
Small comment.
The second dose, I told him not to take it.
دكتور سمير وبعدين أيمن.
Small comment. First, thank you very much, Dr. Hany. The item not to do many investigations for chest pain, at least ECG to relieve the doctor and the patient worry and to
No, we're talking about imaging, يا professor.
Yes.
اللي هو ال CT والقسطرة. إنما ال ECG is standard in the first 10 minutes in the guidelines for 100% of patients, including patients in whom you are 100% sure that they have no من الهيستوري إن ما عندهمش حاجة يعني pleuritic أو كده، بس everybody should get an ECG. 100% of patients should get an ECG in the first 10 minutes.
أيمن.
اوكي النقطة دي مهمة لأن ناس كتيرة بيجوا يسألوني. أنا برد بردين. نمبر 1 لو جبنا 20 مليون واحد قسمناهم نصين، 10 مليون خدوا الفاكسين و10 مليون ما خدوش الفاكسين وتابعناهم 3 شهور، هنلاقي 4700 حالة مايوكارديال انفاركشن، 4200 حالة ستروك، 15000 حالة كانسر في الجروب اللي ما خدش الفاكسين. النقطة انه
الجروب
كل حاجة نو انا بقول ده statistically ما قبل الكورونا والفاكسين تماما. وبالتالي مجرد الفكرة انه الناس طول عمرها بيجي لها جلطة في المخ وجلطة في القلب وسرطان وجلطة في الرجل ومرارة. الفكرة مش انه دلوقتي بقى فيه فاكسين. الناس بتتكلم كانه ما حدش كان بيجي له جلطه ولا اي حاجه قبل كده.
قصده اللي هي correlation versus causation.
This is association وليست correlation.
انا هجاوبك نيرين بس سوري يا ايمن. انا مع ايمن في اللي بيقوله، بس انا I have 2 cases يمكن شفتيه بس هو واخد رايكم فيها. حاجه كانت very strange for me. وان كيس لسه ميت امبارح يعني بقى له شهر ونص في المستشفى عندنا. بريزنتنج الساعه 1 الصبح جالي بانفيريور انفارشن، ما اعرفوش، ما كانش عنده حاجه قبل كده. وبعدين انفيريور انفارشن اللي يبقى الليجن كان 50 بعد توتال اكلوجن اسبريشن بالبيك ثرومبس وما عملش اسبريشن لا في الحالات دي اسبريشن، وبعدين شورت ستان. العيان بعد يومين 3 خد اديني ثرومبس، ادانا اجراستات بعديها بقه بقى مليان كده شويه مش عارف ياكل، جبنا انف واذن قال ده بياخد انتي كواجلنت وقفوه. اول مره اعرفها دي. بعد شويه هنا بطنه نفخت، كونستيبيشن، ديستنشن، انكريتور بنيماتوما، الترا ساوند مفيش. خلاص. وبعدين لقينا قالوا ده انسان اوبستراكشن. جبنا الجراح قال اعمل سي تي. عملنا سي تي في انسان اوبستراكشنز وانت ما عندكيش حاجه هيماتوماس خالص. وبعدين قلنا بس ان دي دايمر عالي، ليفر انزيمز عاليه. بصيت بقى ابنه هو اللي قال لنا يكونش يا دكتور بيقلل الاخصائي له علاقه بالبوست استرازينيكا فاكسين، بقى له اسبوع واخده. بصينا جوجل لقيت ان في اغسطس اخر اغسطس منزلين جايد لاينز في البوست كوفيد فاكسين، وحاطين حاجه اللي بتطلع زي الهيت بدي هيبرين. رحت موقف الهيبرين للعيان وريبليست، قال لك تدي اليكوس تدي زاريلتيت اليكوس للعيان. استونيشنج ان العيان خفت ان السان اوبستراكشن. طبعا الجراح انا ما اقدرش افتحه، انستيزيا ما افتحوش، انزيمز عاليه بتاع الكبد بس، كل الناس شافت بقى. المهم العيان يقول له بس بقى كويس وريكفرت وطلع من الانتنسيف كير وسعداء، obstruction خفت. الجدول اللي موجود جوه بيقول لك وقف الهيبرين، ما تديش حاجه غير دول. العيان لو ريزيستنت اديله حاجه اسمها اي في اي جي، اي في اي جي اللي هو زي اليونوجلوبولينز. ما كانش عنده حاجه بقى خلاص كسر الراجل طلع بره. بعد ما طلع بره في الاوضه بعد يومين ابتدى يجي له برضه تاني ديستنشن، وبعدين وفي ديتيريشن خفيف كده. لقينا برضو الانزيمز عاليه، دخلنا في الاي في اي جي، جبنا الاي في اي جي، مش ما كنتش متعود على الدوز بتاعته، جبناه وسالنا الدوزس وبتاع، تبقوا عارفين يعني لو احتجتوا في حاجه كده هو اساسا بيتكلف 100,000 جنيه في اليوم، يعني 200,000 جنيه. الراجل جبنا الحقن بجراديشن معين. الراجل بعد الاي في اي جي ابتدى يخف شويه. في حاجه اسمها سبلانكنينج انفارشن، دخلنا بقى في الجايد لاين سبلانكنينج انفارشنز. بعد 3-4 ايام العيان ديتيريتد وجاله سيريبرال انفارشن، مكتوبه برضو نفس الكلام سيريبرال انفارشن. ام ار اي بقى وكلام عياده نيورولوجي، دخلنا في الانفارشنز، دخلنا قعد بقى 3 اسابيع على الفنتليتور، تراكيوستومي تريك، خلاص and the patient died. A second patient in the last month برضو كان بيغسل وما عندوش حاجه قبل كده ولا بناء على عينه خالص، خد الكوفيد فاكسين وهو بيغسل. بعد 10 days جالي 2-3 الصبح برضو نسيم، انا دخلت لقيت الارتس كويسه ما عدا 1 فيسل اللي هو توتال اكلوجن ترومبس، ومش بعمل يعني ما كنتش بعمل ترومبس سبيشال قبل كده بقالي بزمن، انا من الناس بحبهم قوي بس بطلتها، بس لقيت اليومين دول كتير قوي في ترومبس اسبريشن ورجعت. انا بس يعني انا مش عايز ده، احنا على فكره مقفولين في اوضه، انا مش بقول كلام لجرايد ولكن انا بقول لك this is what happened to me. انا واحد وفي 2-3 زمايلنا برضو جات لهم حاجات individual. هل انت شفتي برضو؟
ايوه انا I mentioned this because
بس it is rated only to Astra vaccine. الثلاث عيانين او 4 عيانين بتوعنا
في الحقيقه لا
الدكتور صبحي بيتكلم عنها،
انا ده اللي انا شفته.
دي ريكوردد مع الاسترا and recorded with a lower.
انا بعت لكم جايد لاينز اللي نزلت يوروبيان منزلاها من 1 سبتمبر 2021 للناس دول بالذات.
One of the rare complications of the Astra vaccine and it is even less frequent مع الجونسون اند جونسون.
طيب ممكن
اسمها هيت، اتس هيت كيس.
اتس ا تايب اوف هيت على
انت ما تقدرش تعتبرها هيت الا لو يعني
بس
انا جبت الهيماتولوجيست دوروا ما عرفوش على فكره برضو عشان
بس عايز اقول حاجه، ده مختلف عن الكوروناريز.
اللي ريبورتد مع دول كان السيريبرال ساينس ثرومبوزس
بالظبط.
هي حاجه توري يا سيد. اللي اتكى في الموضوع ان بتاع الاشعه اللي بالابط قال اللي لفت نظرنا ايه؟ احنا قلنا ميزنتريك ارتيريال، لا طلع ميزنتريك فين، وبالتالي اصبح فينان ارتري. ذاتس واي وي دايركت اور سيلف ان في حاجه ثانيه.
ده one of the very rare side effects.
انا بقول لك ده فيري رير،
ده فاكسين ريليتد.
طيب احنا بس حاجه صغيره كده قرب الاخر. can we do يعني a recommendation out of this meeting ان احنا بس follow up؟ يعني I myself personally have the last year and a half observed an increased thrombotic events cerebral وcardiac everywhere مع الناس اللي واخدين vaccines الا ستينوفار. شفت الباقيين كلهم، شفت الاسترازينيكا وشفت الفايزر etc etc. especially with the third dose. I had lost one of my patients yesterday بعد الثيرد دوز، وكمان مع فايزر وانذر بيشنت اون ذا سيم داي اهله جايبينه متشال بستروك عشان اشوف. anyways I just want to يعني ask Professor سيد would we have a look على الحكايه ديت just our data اللي احنا بنعملها الانجيوجرامز اللي بنعملها في الاكيوت كورونري سيندروم etc etc. if we can get some data out of this that would be good.
اقول كومنت على ده. هو ده برضو وانا مش بقول كده كمش سخريه خالص، مش عايز حد يضحك. ده زي لو عملنا ريليشن شيب بين الاكيوت مايوكاردال انفارشن والستروك والفطار بالعيش البلدي. اوكي، يعني انت ممكن تقول انا لاحظت ان عيانيني اللي عندهم ستروك كانوا فطرانين فول بعيش بلدي. اوكي، هو ولو عملت دراسة هتلاقي statistical significance جبار. اوكي؟
لا هي هاني مش زي العيش البلدي قوي.
ما انا
هقول لك ليه.
لانه هي الفكرة كلها ان انت عندك النهارده
ناس كتير
millions
واخدين.
of people, millions of people worldwide who are receiving this and who are getting saved from a fatal viral illness. Okay?
And
So
but
to come
I
up
would
with حاجات, it's very important to study everything. Fine. حد يكتب بروتوكول ويستدي ويتكتب مظبوط
I think
ويتعمل.
دكتور هاني
بس هو those kind of studies اللي هي حاجتين very common بيحصلوا طول الوقت، مش معروف اين ليهم صلة، مستبعده جدا جدا جدا، ما حدش تاني خد باله منهم، صعبه يعني.
لا انا هقول لك، هو لا يزال لحد دلوقتي ديفينتلي الناس اللي بيجي لهم MI، يعني الناس اللي هم مش واخدين الفاكسين اكتر من اللي واخدين فاكسين.
طبعا
طبعا يعني انا وي ار نوت سينج سو، انما احنا يعني بس انا اي ونت يو ان انت كل واحد فينا في البراكتس، وخاصه الناس اللي بتشتغل في البرايمري PCIs اللي بيشوفوا العيانين اللي هم جايين بجلطات وبيدخلوا يشوفوا الكورونريز بتاعتهم شكلها ايه. جاست يعني انا بقيت اخليتها زي ما احنا عندنا الدفتر بتاع البرايمري PCI ده بنكتب زي ما بنكتب الريسك فاكتورز، بقينا نكتب التايمنج بتاع الفاكسين ونوع الفاكسين في الشيت اللي احنا بنعملها علشان نشوف في ايه، لان احنا في الحقيقه احنا ملاحظين ان في مجموعه من الناس ما كناش بنشوفهم قبل كده. يعني احنا لما كنا بنشوف عيان صغير في السن ونورمال كرونريز ونلاقي حته ثرومبس دي، كنا مثلا ممكن نشوف عيان كل شهرين ثلاثه. دلوقتي في الحقيقه لا، الريت اكتر شويه من كده.
انا مثلا انا شايف عدد مهول ومأسطر ناس عندها acute COVID واكيوت coronary thrombosis وستروكس ومش فاكسينيت اصلا خالص، يعني caused by the virus. يعني my last patient عندها acute occlusion of the LED, acute occlusion of the left circumflex, zero risk factors apart from the fact that she's 54, no lesions, we imaged, so we treated conservatively, she's fine, but she's lost her apex على فكرة, she infarcted. and zero. لو الست دي كانت واخده الفاكسين كنا اتهمنا الفاكسين، انما the virus itself الفيروس نفسه is so virulent و so widespread.
يعني up to the date عشان بس to make the long story short, up to the date the vaccination is saving lives much more than the vaccination do at harm. فدي this is the end of this.
خدت الفايزر فاكسين. يعني انا خدت التنشيطيه زي ما بيقولوا البوستر دوز، لكن انا بكلمكم بس يعني هي بس زي العيش البلدي دي عجبتني. انت ما ينفعش انك تقول ما فيش رير كيسز، لكن ما ينفعش تعمم وتقول ان لا ما ينفعش، مفيش حاجه في الدنيا كده
100%.
بس يعني هي الفكره
احنا ملاحظين كده، احنا كلنا
100%
كام من مليون واحده مش مشكله
100% ان في سايد افكتس لكل حاجه بتاعتي في الجسم.
لازم يكون. طيب ثانك يو دكتور هاني فيري ماتش، ويا ريتك يعني لو تدينا شويه من وقتك ان انت if you are invited in different places to say this wonderful lecture، لان انا اعتقد انها مفيده جدا، على الاقل هتفتح مجال للناس تبقى عارفه ايه البيبرز اللي اتعملت، واللي عايز يقرا in details هيقراها. This is wonderful effort. Thank you دكتور هاني. Thank you very much.
Thank you very much for this elegant session. It was really fantastic. And we will shift now to another also important wrap-up for the hypertension wrap-up. I can call for Professor Dial Minshawi, Professor Ahmed Hosni, please, Professor Muhyiddin.